Good afternoon. First of all, I would like to thank you for having me here. It's an honor for me to be here, so thanks for that. My talk will be a little bit, if I can do this, yes, bringing you back to the reality on the ground. This morning we talked a lot about bigger concepts and SDGs, etc. I will also talk about the SDGs and MDGs, of course, but a bit what does that mean on the ground? And this is a slide I always show the students that I teach, even if we talk about cervical cancer or something, because I think this is something we need to understand. And this is a quote of Cicero, which is not really new, but we forget about this, especially the people's part. Who are the people? When I came here, I traveled by plane, and when you come if you fly with KLM, the shorter flights, you get this kind of food, and it struck me that they made a point that the chicken that was part of your chicken sandwich had a good life and were treated with respect. And of course, that made me think of my work situation. Also, when you are in a plane and you're so together, I also think of other journeys that people made some time ago, and how they were treated, as opposed to the chicken sandwich. I just had to think that, I'm sorry. And this is the reality where I work, on a day that there were not so many patients. Usually we have one big room, and Alicia asked me this morning how many beds in labor ward, a labor room, and how many patients. Well, 18 beds, sometimes 40 patients. And at the time of slavery, round about that time, or let's put it like this, when slavery was in full force, there were two big revolutions, the American and the French Revolution, and people thought about the rights of man. Now they would say human rights, because it's not only men, obviously. And there were people at that time fighting against that incredible injustice. And these are just a few examples of abolitionists in the United States. And it's telling also that the two black men do not know exactly when they were born, whereas the white woman does. And it's all politics. Somebody said this morning, political determinants. I think it was the big boss of the Oslo University who said that. And I think he's completely right. And you can do something. These were people on Tahrir Square in Egypt trying to get rid of things. So now we talk about Millennium Development Goals. We know we had these 8 goals. Basically, it was about number 1. Poverty. We must remove poverty, and then the other things are really, I think, secondary to that. And if you look at MDG 5 and 4, it was clear to reduce by 3/4 between 1990 and this year the maternal mortality ratios in countries, and what you see here. If you think about this, and you don't think about the women who have to deliver in those beds as different, but if you think about those as yourself, I don't think this is in any way ambitious. This is a joke. If you go to a doctor and his ambition is to have less dead women in childbirth, what is that? That's a given. For most of you, it's a given. What you aim at is a beautiful delivery, a beautiful baby, a healthy mother, a good experience. That's the aim. We talk about aims. That is not always possible, not even in a country like Norway, of course, but that's an aim. It can't be a goal to reach this. So it's not very ambitious. And as part of the IERG, we are looking into information and accountability for women's and children's health, and we produce these reports. Tomorrow I will bring one. I actually forgot them this morning, but I'll bring them tomorrow, so you can have a look. But if you look at the MDG 5 and you look at the global maternal deaths a year, in 1990 we had 520,000 mothers dying in childbirth, basically, and in 2013 a reduction by 43%. So that's something. And on average, every year, 2.6% reduction. Before 2000, it was 1.4. After 2000, 3.5. So there is somebody asked this morning, is there evidence that this whole MDG business, whether that had an impact or not, these numbers seem to say probably they did. But if you would really want to reach those, and I say it again, not ambitious goals for poor people. These are not the goals any country in Europe or the United States would subscribe to. Then you would have needed a reduction of 5.5%. So we're not going to reach this globally. It's not going to happen. And if you ask people, what are the causes of maternal death? Then you get pie charts like this. Women die because of hemorrhage, because of sepsis, because of eclampsia, high blood pressure, whatever. Yes? And if those are the reasons, this is the solution. Evidence-based technical solutions. If you bleed because your uterus doesn't contract, you give drugs that make your uterus contract, etc. Right? This is what happens. But, of course, things are not that easy or that are not that clear. So if you look at where are these mothers who die like that, they're here. They are the global poor. But they are also within rich countries, the poor. There was a nice study in the Netherlands that also showed that within the Netherlands, those of low socioeconomic status are the ones who suffer most. And we have countries where maternal mortality ratios are incredible, 6,000 or even more. So it's a real problem. And this is the reality on the ground. I have to say that all the pictures I show, all of them, I have asked those people in the picture whether I could take the picture and whether I could show them. So it's all with consent. This is Maria. She delivered in Malawi, where I worked for a while. And her baby is alive, which is something. And afterwards, she has to clean up the mess. This is where women their history is taken. This is where you ask, how many times have you been pregnant? Are they from the same husband? Have you had an STI? And you name it. This is a delivery room in Malawi, very much like the one I'm working now. This is where I work now. This is where you then deliver your baby. You go to full dilatation, then you walk up to 20 meters to this beautiful bed to push out your baby. No men, of course, because there are so many women in the delivery room, you cannot have your husband there. It's impossible. This is a resuscitaire, which needs resuscitation itself. This is where we have to try to get the babies back if they have a problem. On the wall, we have all these beautiful window dressing messages. Yes? You have the right to this, that, and the other. Confidentiality, privacy, your own opinion, comfort, safety, etc. It's on the wall. It's really on the wall. And in the street, this is a reminder of what can happen. And this is another picture of what does happen. These are the dead babies that wait to be collected. And this is a picture of a maternal death in where I work now, where the family collects the body of their mother and carry her home. So the question is, why do these women and children die? Again, it says causes. If any one of you believes those are the causes, I go. These are not the causes, really. These are the... If I ask the question, why did she die, and you say she died because of bleeding, then you are just wrong. The bleeding is the answer to the question, how did she die? How did she die? She bled to death. How did she die? She had eclampsia. How did she die? She had septicemia. That's how. But she really died because she's poor, she was poor, she had no voice, and she was female. And in the case of the babies, small. That's why. And I find it really difficult to show a real picture of a maternal death. That's really difficult, and for many reasons. But there's also a problem about to sanitize reality. Yes, we watch all these footages on the news of wars and stuff, but it's always a bit like it's okay. You don't have to vomit when you see it. But in reality, it's nauseating. It's not okay. So this woman, I saw her in the morning in this big room, and she was as good as dead. There was no blood pressure recordable. She had a massive postpartum hemorrhage, and there was nothing, no reaction. But we really moved on and got her back, actually. So this is a maternal death that didn't happen. And I took this picture about 6 hours later, and she looked like this. Because we could do this evidence-based interventions, because we were there, so we could do it, and we did it, and it helped. Because that was the technical problem. Technical problems is a different story. Has nothing to do with the reason why they die. So this one was good, but the next picture is not so nice. This baby is born last Friday, before I came on the plane to here. It's a beautiful baby. It's perfect, but it's dead. Just last Friday. And we have so many stillborn babies in the world. It's one of the biggest chunk of under 5 mortality are stillborns. Something we don't look at because we don't even make an effort to listen to them. We don't listen to the mothers. We surely don't listen to the unborn babies because we have to make an effort. We have really to listen to them. And if we take them on time, we can save many of them. But the bottom line is this, what Mahmoud Fathallah has said many years ago, which is a shame. This is not yesterday, many, many years ago. And this is the truth, in my opinion. And those of you who speak Danish or Norwegian, I don't, can read what this health worker is wearing. And I think that's a reflection of the situation. This means veterinary surgeon, I'm told. There is something veterinary about maternal health care in poor countries and poor settings. And that's not by coincidence. It is because these women, again, they are poor, voiceless, and women. And therefore, we seem to be able to treat them like that. It's okay. For hundreds of years, really. I mean, when did we start to do development work? It started when I was born. I'm now 55. It's a joke. We know we have evidence. This is a research conference. The title is, How Can Research Inform Post-2015, etc. We don't need any research for this. What do you want to research? Tell me. And we have evidence also. We have real evidence that a doula, is something that helps a mother to deliver with less complications, faster, and it's safer, because if a complication occurs, the doula will alert the midwife and or the doctor. Why don't we build hospitals where doulas can be present for mothers, for poor mothers? I tell you why. Because they are poor, voiceless, and female. That's why. Or you'd help me. Maybe you should do research into that, but I don't think so. And that's really the problem. And on the bottom line of all of this is really, I think, that we don't feel they are the same as us. There's this difference. And we don't admit that. And I believe if it comes to the solution, what can we do about this? I think all of us in this room, presumably, want to do something about this. Most of us here are researchers who think that if I do some research, I get some knowledge, I get some information. What was it? Data, information. Translate that into knowledge, and then action, that will happen. It doesn't happen. We know many of these things for hundreds of years. It's not rocket science to get a baby safely. It really isn't. We don't do it. We don't do it. The universities don't do it. The local government, the governments in poor countries don't do it. The governments in rich countries don't do it. Nobody does it. And I think that the solution is it must be, and I'm not blaming the victim. I'm not blaming the victim. I repeat, I'm not blaming the victim. It must come from the mothers. And if we can, because it's in their real interest, mothers and their families, including their husbands, and most men are not monsters. And most men want to be nice fathers. And most men want to have a living wife. We need to have them on board, of course. And I think my assumption is, and I think it's not my thing, it's just the truth, the worthiness of our patients, this Maria that you saw, or the woman who survived her postpartum hemorrhage, she has worthiness. She's worth something. She's worth the world for her family. And we need to give that person space to express what she needs, what she wants. Space in many ways. I learned that at this student conference there was an architect speaking. Very good. Yes, we need physical space that's not intimidating, but that gives privacy, that you can ask any question, in making sure in the setup of the whole thing there's confidentiality, but there's also really respect for your dignity as a patient. And your husband and or mother and or doula, whoever, can be present. We don't do that. I don't understand why we don't do that, other than that we do not respect her. We do not respect her as a dignified human being. But if we do that, I'm pretty sure she will, more often than not, find her voice and say something. And once she has found her voice and says something, that is powerful. And that will lead to change, because she will tell you something. And we have to learn to listen. Someone in the audience this morning said, we are abusing our patients sometimes. I don't remember who it was. Someone said that. And that's very true. Very, very true. And I think we health workers are not trained to understand our potential for doing bad. We all think because we have good intentions and we have all this technical knowledge, we are just good people. We do good. We don't. I think if we for 50 years allow mothers to deliver like this, what good are we doing? And there are tools, yes? Build spaces, understand that the underlying reasons for this are really what we call now human rights abuses. Yes, or what during slavery was called, right of man. At that time, women didn't count even less than today, let's put it like that, in many countries. But there's a whole world of human rights where people can work together to also realize the right to health. And I think we need to collaborate and bring those two streams together. The human rights people, who are not only lawyers, and the health workers. And I think that's really the message. And if that's the case, then we can have hope. Because if you work in those conditions, I tell you, after 20 years, sometimes you have really bad days. where you really think, will this ever get better? What is this? But I think we have to do the right thing. And we really have, excuse my French, give a shit. Yeah, we have to feel it. We have to do something about it. And we have to actually do it. Thank you.
Thank you for this powerful presentation. I think my plan is going to change a little after this. Now, Tarek, I know in fact some of the researchers in the audience here, and I know that in fact many have the same concerns as yourself. And so I'm going to open for a dialogue here, not a set of questions. I think that we are struggling in many ways with some of these issues. And so it's going to be a room, space here for addressing comments and taking what's on your mind in regards to this presentation and thinking how can we inspire each other in order to move forward in a way that we should be more thoughtful over. So, having said that, I'm opening to any comments and for you to add on to this. You can come, of course, with questions, but I mean to add on to it. Okay, so please remember to present yourself.
Hello, I'm John Woodland from Tromsø and from Malawi. And thank you very much, Tarek. If you remember, a few years ago, we were sitting around the table in Lilongwe. You were working there, and I told that maybe I come and work with you. But now I am in Malawi, but you are gone. So, but I know that you work very well in the place where you are. So I'm following in your footsteps, actually, what we do. And you are much better in philosophy than me, so I'm a practical man. But some of what you have told, it's really what we can see every day in the clinic. I know from the rural side that the young girls who are delivering, they don't want to come to the hospital because that's where they are supposed to die. So how can we turn this? And I want a practical plan. We have done some tests, we have done some pilot studies in a place called Chiratsulu, where we really went into the rural areas. We improved every part of the pregnancy care. He even brought the maternal mortality down to 0 for a year. That was a sensation. But who cares about it? That's the point, because when we tried to make this a project for the bigger part of southern Malawi, we were refused because it was not fancy enough science. So that's where I really start to struggle, and I start to think what to do. What we did, we went to every kind of possible donors. The ministry would not help because they had no resources. But finally, now we have support from UNICEF. They will start to help us with that. So my comment, I hope you can reply, where can we really put the attack now to reduce the mortality and the morbidity? I think I put you into my thoughts, and I want to hear yours. Thank you.
Should we take one more?
Yeah, two more.
Okay.
Desmond McNeill from University of Oslo. What you're talking about seems to me to be precisely the political determinants of health, which is what the rector was speaking briefly about. And as you may know, he chaired the commission, and Jashoda Dasgupta was the co-chair. And the aim of that commission, which has now been extended into a panel working on this issue, is precisely to try and address these political determinants of health, primarily at a global level. And so I entirely obviously support that intention. But I would like you to reflect a little. I understand you mentioned that you're on the IERG, and what your experience, because the little I know about that, it seems to me that this political determinants did not feature very strongly in that. And I wonder, firstly, am I right? But also, if you can reflect a bit on the potential for bodies like that, or committees like that, to make a difference in this respect.
I think you can answer those two
Okay,
questions.
yes. Okay. Let me answer the last question first. The independent expert review group is about came into being because Ban Ki-moon started this one Every Woman, Every Child initiative, and out of that came a Commission of Information and Accountability, the KOIA. And KOIA had in its first report a recommendation to have that independent review group, and that's us. And we look into evidence for information and accountability. Behind this lies the idea, and I think KOIA did a good job in identifying it's about accountability. Make governments, make donors, make everyone accountable for their actions or inactions. And that's obviously highly political. And it's very, very difficult because everyone says accountability is a good thing, blah, 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 as long as it's not me. And it's true. Think about it. My private mistakes, for instance, I don't want to tell you. I will not be accountable to you. Yes? Nobody wants that. But in your profession, you have to. And it's a problem. Even with us, with maternal mortality audits, it's a struggle. Even though they are not punitive, they are presumably open and non-judgmental and non-frightening. But we have said in our group many times that we need independent accountability mechanisms on national levels in each country. And we did country visits in Peru and in Malawi. We spoke to the then president of Malawi, Mrs. Banda, who is now replaced by Mutharika again. And they all say yes, and they don't want it. And that's the problem. And that's politics. At this UN level, every time you have to get consensus, etc., etc. And that's why I said in this circle, it's about the mothers. We need to build that momentum, and if we have to understand our work as health workers globally as more than technicians who have technical solutions to something. We have to give our patients the space so that they empower themselves. For me to say I empower someone is the most arrogant thing I could ever say. I can empower nobody, but I can disempower. And I do it every day because I have so many patients, I can't do justice to them. So I'm short with this one, short with that one. I disempower them left, right, and center. Right? If I'm honest. So we have to stop disempowering our patients. And we have to be a good example. On the IRG level, we have recommendations. For instance, in our last report, we had the recommendation to have a commission on health, maternal and child health, and human rights. The idea of that is to form a commission that really pushes for that, have people from all walks of life in it, but not to be co-chaired by the big politicians, but co-chaired by global authorities who really have something to say, who have an authority. That's the idea. I can't say more about that. But accountability is the word, really. And about your question, it's a bit the same answer, because I think the fact that the Malawi does not really want to support this, the ministry, of course speaks also to the fact that if you have disempowered parts of your population, they make less trouble. I mean, we must be a bit, there's this white elephant in the room, poor women, shut up. And that's good for government. Who believes, I mean, how naive can you be that you really think that governments want to empower the poor who really don't have a good life as compared to the not so poor? It's in favor of government to have them quiet. So it's not a surprise to me that is so difficult. But it's civil society, it's this struggle for human rights that can help to change that. And I think we as health workers have a role to play, but we can do it at different levels, but also at the patient to health worker contact. At that level, it starts there and it ends there.
Okay, Johanna?
Johanne Sundby from the University of Oslo. You and I are technically train people in, we're skilled birth attendants, and there are other skilled birth attendants in the room, midwives, doctors. And we are the ones that are supposed to give some assurance to people that what we do is technically sound and informed by evidence. And of course, it's good to have that when you need it. But how can we, in the training of medical professions, midwives, health workers at large, include that other dimension, that we don't only do the technically right things? How can we broaden the scope of training in the field so that we understand what empowerment, what human rights, etc., means in our clinical work?
I have ideas.
John, Pretoria. Tarek, thank you for a very powerful presentation. And I'm going to make a strong statement. And the statement is that I and many of us here may be responsible for many of those deaths. Your presentation is very clear. We don't need science and research to solve many of those problems. We don't need the General Assembly to solve many of those problems. We don't need sustainable development goals to get those mothers and children living. I think we have something really wrong in our moral. How much are we spending on MDGs, talking about MDGs? I mean, vividly you show that, the problems are not setting up goals. What do we do? How do we restore? It's really disturbing. We are here, we are going to go to New York in a few weeks' time, and those of us who are really worried about research, what is wrong with us? What is wrong with the United Nations? If those are the causes if those are the causes of deaths, I want to submit that, in fact, in a good measure, we are responsible for those. And we cannot sit here for the next 3 days and talk about MDGs and so on. Sorry, I'm moved by your presentation.
We're going to take a couple of more, so go ahead. I just want to let you all know that we're running a little over time.
I'm Phyllis Awor from Makerere School of Public Health. I just want to, take this further. The fact is, nobody really cares. The West doesn't care. The governments in Uganda and wherever don't care. And I just asked that earlier this morning. What can we do in the meantime? Because empowerment of women and economic transformation in low-income countries is a generation away or more. Is there any way forward? Or are we just going to talk today and go back to our homes and fancy offices or wherever, and this is going to just be shelved? It will just be one emotional moment, and that's it. What can we really do?
Could you pass it behind you to Fredrik? Go ahead, Fredrik.
So thank you. Fredrik Frøen from the Norwegian Institute of Public Health. I would thank you and commend the IERG for standing up for the stillbirth cause. While we're discussing here that few seem to care about women and children's health, Every Woman, Every Child is still among the most successful initiatives from the UN in very long time. There are few areas that receive that much attention as maternal and child health in general. The Lancet is publishing a new series on stillbirth prevention in October. And in preparation for that work, we've been reviewing every single annual report coming out of all these organizations in the field under Every Woman, Every Child. And the EERG, or IERG, and Every Newborn Action Plan are the two only documents that mention these 3 million deaths in stillbirth, of which 1 million die during delivery. Mm-hmm. Nobody else. You have the Partnership of Maternal, Newborn and Child Health. You have COIA that you mentioned, the Commission on life-saving commodities. None of them mention stillbirth as a word. Not even the annual report of Every Woman, Every Child mentions it, except you and every newborn action plan. The countdown, the latest countdown report, they mention the word stillbirth. At the end of their document, far end, almost last page, they discuss, should we really pay attention to stillbirth? There's a risk that we take away the attention from maternal and child health. As if a live baby wasn't the goal of a pregnancy of a poor woman. How do we move forward in making stillbirth part of maternal and child health? The Partnership for Maternal and Newborn Child Health, they are against including stillbirth in the Sustainable Development Goals. How do we explain that dead babies are not what poor women want? How do we move forward?
Okay, yeah, I think so.
Okay. I try to react to your comments or questions about the education. I'm also teaching at the university, and I was teaching in Namibia also, and we clearly had human rights at the core of the obstetric and gynecology curriculum. And it is very, very important to rethink what does it mean to be a health worker? What is the aim of it? For some people, it's pure a technician. And if that's what you want to do, that's probably not good enough. And maybe you should create courses in your universities or educational institutions where you clearly say that's not good enough. Because our aims, our goals are so unambitious. They are not ambitious. If we want to prevent death, that's no ambition. Sometimes that is a good thing, of course, because there's nothing else you can do, but otherwise that's not good enough. And for instance, in the course we give also in Zanzibar, when a student has to present something, any topic, he or she has to give one slide in which he says, what are the ethical dimensions of this problem, whatever it is, a rash, it doesn't matter, a pimple somewhere. What is the ethical dimension? But then you have to think about it. And I think that's one start. But of course, I don't have the solution for this, but we have to think about it and make it more and more inclusive into how we see ourselves. If you look, my specialty, obstetrics and gynae, if you are now trained, I'm trained in the Netherlands, if I'm now trained, I would become like a fertility person or an obstetrician or an oncologist or an endoscopist. It's very technical. We forget what it's all about. And in the context of poor countries where women are really, as we said, voiceless, and we have to change, we have to contribute to them finding their voice. That's what we have to do. And be humble and not speaking for them. What do I know about you? How can I speak for you? No. But I can disempower you that you shut up in that situation. And that we have to stop doing that. The other thing about stillborns, I think...
Wait, can I just add here? I appreciate that all of you skilled birth attendants have taken the entire responsibility and put it on your shoulders, but that is in fact not the case. The case is that it is a shared responsibility. There are others that have a responsibility together with all of us in this. So, I mean, health financing is an issue, poverty is an issue, I think education is an issue, and I think all of those things are building a society and people up and are right in a way. So I think it's, per se, is how do we work together in order to better get a cohesive sense of building up a nation and empowering, and each one empowering themselves in order to use their voice. Now, I think there is another aspect, and that is an accountability, and I would like to just say something about that, and that is, okay, maybe all of these efforts that one has done can be criticized. Maybe the accountability work or the UN or the global strategy or all of these can be criticized. But it could also have been even worse if we didn't have that. And I think that there is something powerful with accountability in ensuring that what actually is counted counts. And you do need that kind of data, and you need that kind of credibility of the data that is counted to be able to be used. And that is something that the Commission for Information and Accountability did contribute. So it did say, and there are 10 recommendations, and the first recommendation is in fact CRVS. It is, the other recommendations are about strengthening information systems. It is about agreeing to monitor and progress and hold each other accountable. And there is also the recommendation of strengthening district information systems. And the last one is to establish the independent expert review group in order to report back to the UN Secretary General. Now, these might not be perfect things, but boy, are they better than not having them, because that becomes even more invisible.
But I have to add to this. It is important that it comes to the individual level. Anything else is just not good enough. And all these commissions and all these reports and whatever have to be translated to that level. And we have to push that through, the last bit. And that was the motivation for this, our recommendation about this Health and Human Rights Commission. I want to say something to the lady from Makerere, because this is my problem also. What can you actually do? And I think really on the practical level of today, we used to say in our department that the surname of our patients is Now. We have Fatima now, or Rahida today. Very rarely we have a Maria tomorrow. I've never had a patient whose surname was post-2015. Never. And we have to do this on our scale. As you say, national governments and all these, also these big organizations, they are big, slow things which we have to influence, and they are willing. It's not that they don't want, but for the short term, they are not very useful. But we are useful. As you say from South Africa, let's do something. Let's speak to our patients. Let's do it. We are on the ground. We can do something. That's really, until the big machineries, NORAD, others. Yes, I mean, it's not this is not criticism. This is just how the systems, they are very slow. They are very slow. And yeah, about the stillborn, I think we get there slowly, slowly. I mean, you saw the picture of this stillborn baby. We have to get there very slowly because things take time. And someone this morning also said something we at IRG are hammering on all the time, that's quality. Yes, we need quality of care, we need also quality of data. You know, as you say, that everything that is counted counts, but there are things that can be counted, but they don't count. And there are things that really count, and they cannot be counted. They are not quantitative. They are qualitative. We have to define quality, redefine quality, and we have to try to find indicators and measure possibilities to get a sense of that, even though we know we cannot actually measure it. And this is these are challenges, but that's a good challenge because we get away from numbers. And we know, for instance, in Malawi, they have increased the output of clinical officers enormously without increasing the staff that teaches them, without increasing any books, nothing. You know what you get when you do that. Sorry.
Okay, so